the idea here is put everybody in the same page. So I will discuss a lot of the abdominal wall anatomy applied to what we're gonna do in the next couple of days. These are my disclosures. There are 2 or 3 papers and 1 video and 2 papers that are studying this subject. I realized that it's important for you guys to have. This is probably the best video of anatomy that we have on YouTube. It's from our friend Igor. It describes everything that the lights, yeah, please. It describes everything that we're going to discuss during this next 2 days and what we're going to see. So this one you should probably have in your armamentarium. And this, to understand, we're going to discuss onlay, sublay, preperitoneal, pretransversalis, pre-whatever it takes. And these are 2 classifications that will deal with the name and the position of the meshes that we're going to discuss. For me, to be sincere, this first one, which is more recent, is two-way complex, and a lot of people didn't realize a lot of the planes that we're going to discuss. So we're going to take care, and we're going to focus on this one that is the most used so far. So I don't want to be boring with this subject, but it's tough not to be boring when you talk about anatomy. And we're going to discuss basically the anterolateral abdominal wall. So we're going to focus especially on the 3 muscles, the external oblique, the internal oblique, and the transversus, which will be making a compartment for the rectus muscle, which will be in the central part of the abdomen, and what we call the rectus sheath. We're going to discuss anterior rectus sheath, posterior rectus sheath, anterior component separation, and we're going to discuss these 3 muscles making some arrangements to make like an envelope in this central muscle, which is the rectus muscle. And we're going to discuss these 3 spaces, which are very important. The space between transversalis fascia and peritoneum, where we can put meshes, and we're going to use it during this day. So these are the muscles. As I told you, in the central part we have the rectus abdominal muscle, and we have the 3 muscles in the lateral part, which will provide this they will create a space to contain the rectus muscle, and we will understand that this will vary with the abdominal wall position, and we will discuss this during today. This muscle is not important for us today. We're going to just cite it here. So that's a dissection of the anterior abdominal wall, where we can see the rectus abdominis with this sheath open. So we are seeing the real muscle with their origin insertion. We're not going to go through this. This is the view when we just take the skin and subcutaneous fat. And this is, like I told you, this is this involutorium that we have in the rectus, which we call into rectus sheath. So the idea here is to create, because if we start studying the abdominal wall anatomy and you study the abdominal wall, especially the forces that we have in the abdominal wall, we're going to learn that we're not prepared to be in the stand position. We know a lot of people that don't deserve it. But we are not. Our configuration is not to stand. Our configuration is to walk in 4 steps. And this is very interesting because you're going to see that we're going to develop a fragility part in our abdominal wall, which is the inguinal region. That's why we have so many problems there. So that's the appearance when we take out the skin and the subcutaneous fat. And this is when you take out this tendinous part of the rectus sheath, which is formed by these muscles, as we're going to see during this lecture. So we're going to just see the muscles. I don't want to go through all of these. The first muscle is the external oblique. It comes from posterior to anterior, from lateral to medial, and from cranial to caudal. So it's like if you put your hands in a pocket. And attention to this. All these muscles, they're gonna, at some part of their trajectory until the midline, they're gonna not more being muscles, they're gonna transform into a tendon. And this transition, we're gonna give name, and it's very important for us during the dissection. And this transition from muscle to aponeurosis is what will create the rectus sheath, the posterior and the anterior components of them. As you can see, this is the muscle that is just below, is the internal oblique. His fibers come from posterior to anterior, from lateral to medial, but they come from inferior to cranial. So they do a 90 degrees configuration with the external oblique. This is external oblique, this is internal oblique. And the most profound muscle is the transversus abdominis, which is very important. And as the name is saying, their fibers will run in this yeah. And then, as you can see, for each of these muscles, we have a different position for the transition between the part that they are really muscles and the part when they turn into fascia. And this is very important when we try to understand the linea semicronaris and a new concept that some guys in Europe developed, and I will bring to you at this time. So when you get all these three muscles working together, you're going to have some vectors that will try to pull the abdominal wall in this direction. And this is very important. This is why we always try to close the midline, because this is basic physics, and this is reported in a series, different ways in the literature. But as you can see, you always have a result that's normally is to this position, a little up, and if you, this is basic physics. If you have these two forces acting the same way on each side, they're gonna, the result will be zero. So you won't have the tendency to have this open. That's why if you leave a hole in the abdominal wall, or if you have an ostomy, the tendency is always to have an increase on the size of this hole, because you don't have the other counterpart to turn this into a zero forces trying to open this space. So this is very important. This is something from a publication in Brazil showing the same thing. So you have external oblique, internal oblique, and transversus, and the result will be a little bit for this side. And as you can see, if you have the counterpart doing the same force, this will be a neutral result, and you're going to have, that's why we try to always close the midline, and the idea is to understand these vectors to try to understand why we should do this. Two important things that will help you guys to understand why we prefer the retromuscular space and why we avoid to do big subcutaneous flaps are understanding the vascularization of the skin in the abdominal wall region. So that's what you see when you do some angiography. You see a lot of perforators close into the umbilical area, and if you raise a flap like this, as we're going to see in the next slides, usually the vascularizations come from up and below. And if you raise a flap like this, these center areas, especially if you cut these perforators, will have less vascularization and will be more prone to ischemia and infection. So this is very important. That's why, and I'll show you in some details, what's going to happen. That's the way the neurovascular bundle runs to help innervate and vascularizate the rectus abdominis. So here, this is a cross section. This is lateral, this is medial, this is a left rectus sheath. So you can see external oblique, internal oblique, and transversus abdominis. And you see the neurovascular bundle, it comes between internal oblique and transversus abdominis, and it will lie on the posterior on the posterior part of the rectus, between the rectus and the posterior rectus sheath. And this will be very important for the nutrition, not only for the rectus abdominis muscle, but this neurovascular bundle will raise the perforators, what I show on the next slide. So this is what happened when I do an incision and try to dissect this space in the anterior part of the rectus sheath. I'm going to devascularize all of this, and the vascularization will come just from the sides. That's why we have ischemia, that's why we have an increase on the chance of infection. In this part, we are seeing the transversus muscle, and what is raised here is the internal oblique. And as you can see, especially the nerves, they will lie between these two layers. So this is a cross section, this is the right side, posterior, anterior, this is the rectus, this is external oblique, internal oblique, and transversus. And as you can see, as soon as the nerve comes, he will stay most part of the time in between transversus and internal oblique. And at some part of the time, just lateral to this line where the muscles turn into aponeurosis, this one we're going to call semilunar line, just before the innervation to the external oblique comes to this side, to the side. So this will help us to understand why when I'm doing anterior component separation, I have to do my transection here, because I will maintain this part innervated, and I will create, when I put the mesh, I will create a functional external oblique and a functional which have rectus, internal oblique, and transversus abdominal. So this is very important, and this helps us to understand why in the posterior component separation we have to keep this space. We can't transect the internal oblique, because if you reach the internal oblique, for sure you have transected the nerve. So this is very important to understand. So as I told you, this you have superficial layers, these you have the profound layers. As you can see, the vascularizations come more in a cranial to caudal or caudal to cranial fashion. It comes more in the longitudinal sense. This is a dissection that we're going to go through all the steps. So here we just take the skin and subcutaneous tissue. As you can see, the rectus sheath is still intact. So right now we have external oblique. Right now we're going to take all of these layers. So right now we are a little more profound in the abdominal wall. We are still on top of the rectus sheath, and we start seeing the superficial nerves. So here we can see iliopogastric, here you can see ilioinguinal, here you can see the cutaneous lateral nerve. So right now we're going to start trying to take out all these muscles. So what we're seeing right now, we take out the anterior rectus sheath, and we start to see the nerves coming as a metameric distribution. So that's why when we do incisions that do not respect the midline, always when you go through all the layers, everything from that point that you cut to the midline will be denervated. The muscles will get atrophic and you have more chance of hernia. That's why we try to avoid these lateral incisions that do not go through the midline, because everything from that point to the midline will be denervated and will be atrophic. Okay? So let's take out the next layer. So we take out the rectus. Right now we are seeing the nerves. So this is transversus abdominis, and I will ask for your attention in this. As you can see here, you have the semilunar line for external oblique. Here you have for internal oblique, and here you have for transversus. So as you can see, the point where the muscle transitions from muscle to aponeurosis is different in each layers. And that's why some friends from Europe try to do new concepts, trying us to understand better the surgery that we are doing. So there are some peculiarities, as I told you, in the vascularization. As I told you, there are some perforators close to the periumbilical area, which everybody, even in open surgery, even in anterior component separation, most of people try to preserve these perforators, and this is, you can see the umbilicus and all the perforators that you can have on this part of the dissection. So as long as I create flaps, as I raise flaps here, I will have this vascularization impaired. So my patient will develop ischemia. And here you can see what I showed in that drawing, the perforators just coming in the middle of the rectus to vascularize the skin. This is a very interesting drawing. As you can see, the vessel is here, and it comes from posterior to the rectus until vascularization of the skin here. So as you can see, if I do an incision here and go in front of rectus, which we are very used to, which is an on-layer repair, I'm going to desvascularize this, and the vascularization will come just from the sides. On the other hand, if I go through here and I go in the retromuscular space, or in the preperitoneal space, or even in the IPON, intraperitoneal space, I will preserve this. The vascularization of the skin and subcutaneous tissue will be held, will not be impaired, and I will have at least 3 to 4 less occurrence of surgical site infection in this situation compared to onlay. So that's why we discuss and we try you guys to understand the retromuscular positions. Not only the retromuscular position, but the sublay position, which includes preperitoneal and IPON, as I will show you. The innervation has these peculiarities. There's a landmark that is the umbilicus. The umbilicus is the reference is the 10th nerve. So we have to keep this in our mind. This is a dissection where the external oblique and the internal oblique were just cut off. So this is cranial, this is caudal, this is transversus muscle, this is the linea semilunaris for the transversus muscle. As you can see, all the nerves, all these nerves that I showed here, they come exactly in this space, in between transversus and internal oblique. So this is very important for us to preserve this layer. This is one of the most common errors that we can do when we are performing TAR. If you dissect and you see the nerves when you're doing TAR, probably and you see in the lateral part, probably you're doing something wrong. So this is very important to understand. You should keep the plane and maintain the muscle, not to injure these nerves, especially when you're doing the lateral dissection. And we're going to go through this. And this is very important. So this is when we take out external oblique, internal oblique, the rectus muscle, and we are seeing is the posterior rectus sheath, and we're seeing the transversus muscle with the nerves in front of it. So let's go to the formation of the rectus sheath, which is formed basically by these 4 structures: the external oblique, the internal oblique, the transversus abdominis muscle, and the transversalis fascia. So this is a very interesting picture. I really like it because it shows 2 things. First, that the semilunar line is different in each of the struts that we are, each of the muscles that we are talking to. So if you go to external oblique, which is cutted here, it's here, the internal oblique here, and as you can see, the transversus, it's almost even in the more lateral position. And this will be very important when we try to start doing our TAR procedures. So let's see how this, how the rectus sheath is encased by this rectus sheath. So what happens? In the 2 superior thirds of the abdominal wall, the formation comes from, so here we have external oblique, internal oblique, and transversus muscle. All of them, when they stay close to the rectus muscle, they turn into an aponeurosis. And on the 2 superior thirds, all the external obliques cross and reach the other side in front of the rectus muscle. The internal oblique, it splits in 2 layers, one anterior and one posterior. And the anterior one goes in front of the rectus muscle, the posterior comes here, and will reach the posterior, the transversus abdominis muscle forming the posterior rectus sheath. So, in the two superior thirds of the abdominal wall, the anterior rectus sheath is formed by the aponeurosis of the external oblique and by the anterior component of the internal oblique. The posterior rectus sheath is formed by what we call the posterior lamella of internal oblique and the transversus abdominis muscle. And the last layer is the transversalis fascia, which is the most deepest, the most profound. What happens in the inferior third? All of the muscles, they cross in front of rectus muscle. So the external oblique aponeurosis come in the front, the internal oblique aponeurosis come in the front, the transversus abdominis come in the front. And then the only structure that will provide the posterior rectus sheath on this part will be transversalis fascia. And we have a clear determination in the abdominal dissection. To see this, we're going to see right now. So that's what we're going to see. These are the 2/3 where you can see the posterior rectus sheath formed by the posterior lamella of the internal oblique and transversus abdominis muscle. And when you come to the inferior third, the only component that forms this is the transversalis fascia. The anatomical demarcation for that we call arcuate line. And as I told you, there's another important anatomical landmark in this part, that is the semilunar line. The semilunar line, and that's what we should take care, is where we start to see the neurovascular bundles come to innervate the rectus muscle. And I draw this in with these colors like right here to show that this will be our lateral limit of dissection. If I want to go further lateral, I have to do what our friend Nowitzki described, a posterior component separation, trying to avoid the lesion of these neurovascular bundles. And we're going to go through this all over in the next 2 days. So this is very important to understand. If I decide to do a retromuscular dissection, the size of my mesh is already determined by the size of the posterior rectus sheath. If I want to go lateral to that, I have to add some kind of component separation. This is a sagittal section where we can see the anterior rectus sheath, the rectus muscle, and we can see the posterior rectus sheath. And this is the point of transition. This is the arcuate line. Okay? So sometimes you can realize all of these layers in the CT scan. This is in the 2/3 of the abdomen. This is on the lower third. But this is very important for us to understand these planes and understand where we can reach these limits and what we should do if we want to go further lateral. So that's why when you try to understand the anatomy of the posterior component separation technique, that's what we're going to have. You open the posterior rectus sheath, and as you can see here, you see the anterior rectus sheath, the rectus muscle. You start seeing the neurovascular bundles, and you're going to start opening this layer, the posterior lamella of the internal oblique and the transversus abdominis aponeurosis. Try to avoid injury to these nerves. So if you want to go further lateral to the semilunar line, you should develop this space, okay? Why? Because you want to prevent lesion to this muscle and you want to maintain integrity of the innervation of the anterolateral abdominal wall. Try not to go too much beyond my time. This is a concept that was published last month, which some friends from Europe, they developed a new concept, what they call AET ambivium. What is the idea? If you go to the anatomy papers, the linea semilunaris is only formed by the transversus abdominis. The thing that I saw, I said before, oh, you have a semilunar line for each of the strats, the layers, is not true. If you go just to anatomy. Of course, we as a surgeons understand that. So Linea semilunaris in the crude definition is just a transition between the muscular and aponeurotic part of the TA, just for that. I didn't realize that until I go to the anatomy books and is that. We describe for external and internal obliques, but it's not true. The semilunar line is just for that.
There's a difference between anatomy and...
Yeah, of course. That's what exactly what I'm saying. And that's what I think the guys try to do here. So... I will not say it, I'll just show it, okay? Of course, tomorrow we're going to say, oh, I'm cutting here on the semilunar line and whatever. So, they propose this term just to put the external oblique transition and the internal oblique in the same page. So, that's the idea, okay? So, they did an acronym, external, internal, and transversus. And when you look this in the anatomy, this is the right side of the patient. You're looking from up to down, so from cranial to caudal. So this is lateral, this is medial, okay? This is the external oblique turning into aponeurosis. This internal oblique delaminating, so the anterior component and the posterior component. This is the posterior, this is the TA. So here you are in the 2/3 of the abdominal wall, showing that the anterior rectus sheath is formed by external oblique aponeurosis and the anterior lamella of internal oblique. And the posterior sheath is formed by the posterior lamella of internal oblique and the transversus abdominis muscle. So basically what they are doing is what we already do in the clinical practice. We always try to avoid injury of any of these parts because we want to prevent the lesion of the neurovascular bundles. That's the whole idea. So that's what they described for us. We will probably continue to say semilunar line, okay? But just for you guys to understand. And this is very important because I understand what they tried, Yuri. Because in fact, when we transect the transversus abdominis muscular here, we transect the linea semilunaris because in the inferior part, we always cut we cut the aponeurosis, we don't cut the muscle. There's no muscle there. If you go with the top-down technique, the bottoms-up technique, you transect the linea semilunaris by definition, you know. And what they try to show is that the dissection, they call the semilunar line here because it's the part where the muscle transitions into aponeurosis, but the section is doing here. And this is exactly what we do in surgery. In the inferior part, we transect aponeurosis, and in the superior part, we transect the TA muscle by itself, including with the posterior lamella. So I understand the idea. It's just for you guys to show the concept. What we're going to do this white line on the next 2 days. But the main point is understand where the nerves are and avoid injury to the nerves. That's the most important part.
Can I make a comment?
Oh, of course.
So, actually, what we're looking at is a junction between anterior and posterior rectus sheath.
Yeah.
We call it linea semilunaris because it's not just
Perfect.
It's not just the junction between the muscular and aponeurotic.
The transformation. Yeah, I agree.
That's actually going to happen
Way more medial.
Right?
I agree.
So, and while we always want to preserve the nerves, the most important thing to avoid is to not to disconnect the lateral abdominal musculature from the rectus, because then it all. So that's what we call a semilunar line injury, because we call essentially the transection of the junction of the lateral anterior abdominal wall through the aponeurotic structures there, right? So if you're on the wrong plane, cutting the nerves is a problem, but not as big a problem as cutting
through all this.
The other layers.
Yeah.
And so that becomes clinically the most significant thing. The TH below the arterial line, is not cut through the aponeurotic junction. The aponeurosis is very, very thin.
Very thin. Yeah.
It actually fuses. It's sometimes hard to separate from the cell structure.
I agree.
But the importance is that your ceiling is intact. The ceiling, and we'll look at it.
Yeah, we'll look at it
Because
soon.
some of it is the theoretical science, but some of the practical knowledge from all of this, the importance of this, is that to recognize the junction between anterior and
posterior rectus sheath.
And we can call that line
Whatever.
what we call that line is because it's not really in the biblium, it's not, we call this similar line.
Probably it's in the
Here,
middle.
We're saying we call this a similar line,
Mhm.
which by strict definition, for clinical purposes, we can call it a line. But the idea is that, interestingly, the tar transection parallels the yellow line more than the white line, right? Because we're gonna aim more medial in the upper abdomen. In fact, that's one of the things that
Yeah.
maybe I'll show a little bit later. So it's important to also understand some of these are kind of anatomic drawings and some of them are clinical, but we want to be discussing or applying clinically relevant anatomy, and the most clinically relevant stuff that you just pointed out, nerve preservation, but more importantly, maintenance of the intact junction between lateral muscles and the rectus muscle. That's the injury. Because if those two are disconnected, by definition, the nerves are cut.
I cut, yeah, yeah,
That's
yeah.
the way to do. But most importantly, the lateral muscles, like we said at the beginning, no longer have an opposition. So the injury will continue to grow because the lateral muscles will continue,
We'll continue to contract, yeah.
And those hernias are very hard to fix because it's a very contracted lateral muscles. They're so diseased that we're going to have a hard time restoring them.
pulling back.
And it's not only because of the hole, because the holes aren't necessarily that big, it's just everything is so stiff and you can't do it. So that's the injury, guys. So we're going to be worried about preservation of that anatomy in terms of muscular, fascial anatomy. And the nerves, to me, are just landmarks.
Yeah, no, I agree with you, and I think what they came with this idea, I think they are thinking the same of that we are discussing. Try to avoid the Mickey Mouse hernias.
Right, no, for sure. But there's some people, if you really think about it,
they try to do this to understand that this as the lateral border of the rectus muscle. They put on a paper that they try to show where's the lateral border of the rectus muscle, exactly to avoid the injury that you're saying.
We can always, right. But I think it's a junction between anterior and posterior sheath.
I agree.
Because that's all you care about. And in fact, again, when you look at it clinically, you look at the rectus muscle, and the lateral border of the rectus muscle during the open tar is not that line. You actually sometimes see another centimeter of the anterior fascia, and I think that's where the errors come. People look at
Go on
muscle
that spot.
and they cut the junction. So
Agree.
I think there's a little bit of kind of cute, some anatomic pictures, and I get it, but I don't think the similar line is truly intersected by the TA, especially what we view as a clinical.
And I think what you said is very important because when we are dissecting, especially the inferior part, we try not to go to the ceiling. That's the most important part of the dissection. I think this is what we're going to discuss in the next days. Thanks, man. So that's the idea, and this is exactly what Yuri is showing. This is the caudal part, and this is cranial. So we're going to do this dissection in the muscle, as you can see in this part. And this is what he calls, and this is what probably Yuri was saying. This is the junction between the anterior and posterior rectus sheath on the lateral aspect of the abdominal wall. This is the most important part to preserve. That's what I'm supposed to talk right now. But so that's the idea.
But I just don't think the linear seminar is that.
No, the linear seminar is by definition is supposed to be this. I think we will probably cut here. Try to avoid. This is what we are saying. You're never gonna go through this part. You wanna go this. Exactly to avoid the lesion of the anterior rectus sheath and to have transection of all the layers. So they described this junction between something that we have in anatomy for years, which is the junction between semilunar and arcuate lines, and they call it the fulcrum abdominis, which is this. So the linear, this is the arcuate line, and this is the semilunar line, or the etium bivium, as they say. So this is a landmark that we use to start the bottoms up dissection. So to finish the position of the meshes, as I told you, this is the paper that I suggest you to use. You can put the mesh in front of the anterior rectus sheath. That's what we call onlay position. You can put in between the rectus muscle. This we don't use anymore because it just had a high recurrence rate. You're never going to use it. And you have the sublay position, which comes from all other positions. You can divide it in the preperitoneal space, which is between the posterior rectus sheath and the peritoneum. You can have it preperitoneal, you can have it retromuscular, which is between the rectus muscle and the posterior rectus sheath. You can have between posterior rectus sheath and peritoneum, which is preperitoneal, and you can have it just on the deeper space, which is inside the abdominal cavity, which is intraperitoneal. These are the definitions. As I told you, you can have this in your papers. That's what I told you, that is far more complex. I won't go through all of this. There are some spaces that we're never going to be, and a lot of them didn't get even consensus between the experts, so I'll go with this classification. So my take-home message, remember this space, and for each space we're going to discuss something. So for the only part, you can have with the robot, you can do SCOLLA. You can do what we call robotic onlay technique, which Flavio showed in the last Congress. For intraperitoneal, you can go IPUM or IPUM plus. I missed a plus here. You can do the technique described by Salvador, which is some incision in the aponeurosis, which we call LIRA. And when you go sublay, you can go through each of these spaces. If you go preperitoneal, you're going to do a TAPP as you do in inguinal hernias, and you're going to put your mesh in the in between the posterior rectus sheath and the preperitoneal space. This is tough, especially in the upper abdomen, where the peritoneal is very attached on the not on the midline, but on the posterior rectus sheath. Sometimes it's very thin. It's difficult to achieve this space. In the retromuscular space, you can put a lot of names here for even for surgeries that you're not doing with the robot. But the idea is to come in this space between the rectus muscle and the posterior rectus sheath, and you can go lateral as far as you want to go if you do the posterior component separations. I will do a small merchan, Rodrigo. We are preparing an international symposium in Salvador, Bahia, which hands-on courses will be, since next year we don't have the Brazilian Congress, the idea is to have almost 200 people going to this symposium, and I invite you guys to read this QR code. And someone who want to have more experience in abdominal wall, we have our post-graduation course, which is a post-graduation course in its essence. It's 4 modules, more than 350 hours, just dealing with abdominal wall, open, laparoscopic, robotic, and whatever it takes. Thank you guys, and I hope. I don't think was it, man.